All set to go. Thanks everyone for joining. Good morning, everyone. Welcome to the October 17th, 2024 Licensing Committee meeting. My name is Sung Oh, Chairperson of the committee. Before we convene, I'd like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. As I facilitate this meeting, I will announce when we are accepting public comment. I have advised the meeting moderator to allow 3 minutes to each individual providing comments. We'll begin with public comments for individuals attending in person in Sacramento, followed by public comments by individuals participating via WebEx. This approach is necessary to facilitate this meeting. Before we get started, I would like to ask staff moderating the meeting to provide general instructions on the process for providing public comment via WebEx. Trisha.
Thank you, Mr. Board President. Before we get started, I would like to remind board members and staff who are not speaking to mute their microphone during today's meeting. If background noise is detected as a result of unmuted microphones, I will mute those microphones. There are members of the public in the audience and meeting minutes are being taken, so we ask members and staff to please identify themselves before speaking. For the purposes of today's meeting, when the board president opens for public comment, we will be utilizing the WebEx question and answer and hand raise features to facilitate public comment. When public comment is called, I will open the question and answer feature, which you will hear me refer to as the Q&A, and members of the public who wish to make comment can click on the Q&A icon, type the word comment in the text box, and click on the send button. To utilize the hand raise feature, simply click on the hand icon next to your name to raise and lower your hand. Those who have called into the meeting can dial *3 to raise and lower their hand. And with that, I return the floor back to you, Mr. President.
Thank you, Trisha. As always, I'd like to take a roll call to establish a quorum. Vice Chair Trevor Chandler.
Present.
Thank you. Good morning, Trevor. Renee Barker.
Good morning, licensing member present.
Good morning, Renee. Jesse Crowley.
Licensing member present.
Good morning, Jesse. Satinder Sandhu.
Licensing member present.
Good morning, Satinder. And I'm not sure if Jason's here. Jason Wise? Jason may not be here today, and I'm here. A quorum has been established, members. We have a full agenda for our meeting today. I ask everyone participating today to be respectful of the work before the committee. We encourage participation by members of the public throughout our meetings at appropriate times. The committee respectfully requests that when comments are provided, they're done so in a professional manner, consistent with how the committee conducts its business. Before we move to the next agenda item, I would also like to remind board members participating via WebEx to please remain visible on camera throughout the open portion of the meeting. And members, if you need to temporarily turn off your camera due to challenges with internet connectivity, please remember to announce the reason for your non-appearance when you turn off your camera. Finally, I would like to ask staff to send out a link to all board members when the live stream of the meeting is available. This will ensure members that are interested have an opportunity to review the meeting prior to the next board meeting. Thank you, everyone. Moving on to the agenda item 2, public comment on items not on the agenda items for future meetings. I will now ask the moderator to open the line for individuals to provide the opportunity to provide public comment on items not on the agenda. You're not required to identify yourself, but may do so. I would like to remind everyone that the committee cannot take action on these items except to decide whether to place an item on a future agenda. Accordingly, if your comment pertains to an item on today's agenda, please save your comment for the public comment period specific to that agendized item. Members, following review of the public comments for this agenda item, I'll ask members to comment on what, if any, items should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the committee and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. Alrighty, any members of the public?
Thank you so much. This is a moderator. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen and send it to all panelists, or simply raise your hand. We are displaying instructions and we'll give you a moment.
Hi, this is Anne. Just so the record is clear, there is a member of the public in the Sacramento location, but no public comment.
Thanks, Anne. Trisha just jumped the gun there, so
No.
efficiently. So thank you. We're ready for WebEx, Trisha. Thank you.
Thank you. And I'm seeing no requests for comment at this time, so I return the floor back to you.
Thank you, Trisha. Members, anything that you want us to talk about in the future licensing committee meetings? Always want to open the opportunity. There's a hand raised, Trisha, so let's go back and open that up.
Yes, my apologies. They sneaked in there. All right, so Basma Sadala, you'll have 3 minutes for your comment. I'll give you a 10-second warning, and you should see a prompt to unmute yourself. There you go, you're unmuted.
Hear me?
Yes.
Okay, perfect. Thank you so much. I wasn't sure on how to open my video, but I don't think it's allowing me to. Is that something I believe you were saying we're required to be on the video, correct?
Oh, that was for the board members, but for members of the public, you don't have access to turn on your camera.
Okay, no worries. Thank you so much. I appreciate it.
Oh, of course.
Thank you today for the opportunity to speak before you. My name is Basma Sadala, and I'm here on behalf of a few pharmacy residents who have devoted the last 8 to 9 years of our lives to becoming pharmacists. And we're here today because we are just 2 days short of the 45-day waiting period between our September 24th exam and the next available test date on November 6th. This seemingly small discrepancy has a profound impact on our futures, and we humbly ask for your consideration. We understand the importance of maintaining standards, and we respect the regulations in place. But this is not a case of bending rules. It's honestly just a plea for fairness, or at least 2 days. That is all that stands between us and the next step in our careers. And that could be the difference between beginning our journey as pharmacists in a timely manner or being delayed for months. If granting a waiver for the 2-day shortfall is not possible, we ask that you please consider adding another testing date after November 8th, which is when we are eligible to take the next exam. This would allow us to continue our paths without unnecessary setbacks and ensure that we can begin serving the patients and communities we've trained so hard to care for. We've worked very long, and this delay would not just impact us professionally, personally, as well as financially. And please, we are asking for your understanding and compassion. A small change today will have an immeasurable impact on our futures, our careers, and the patients who are waiting for us to serve them. Thank you for your time, your consideration, and your commitment to the future of pharmacy in California. We trust in your leadership and hope you will help us cross this final hurdle.
Thank you for the comments.
All right, our next comment is from Melissa Mazdaza. And Melissa, you should be able to unmute yourself. There you go, Melissa, you're unmuted.
My name is Melissa. I'm also a PGY1 resident, and I recently took my CPJE exam on September 24th. I'm here to respectfully request an additional CPJE test date in November for candidates who find themselves in a similar situation as mine. Many of us are facing the real possibility of losing our hard-earned PGY1 residency and our income for the year. These positions are more than just jobs. They represent years of dedication, sacrifice, and contribution to patient care. We have spent years preparing ourselves to serve as pharmacists. The only barrier standing between us and the opportunity to fully contribute to our profession is the 45-day waiting period, which currently prevents us from retaking the exam on November 6th. By granting an additional test date after November 8th, you would help ensure that we can continue our professional journey without disruption. Thank you so much for your time and consideration.
Thank you for the comments.
All right, and the next comment is from Jesse Chen. Jesse, you should be able to unmute.
Good morning, members of the board. My name is Jesse Chen, and like my other residents, I would also humbly request an additional CPJE test date. I understand the weight and the meaning behind becoming a licensed pharmacist. I've personally seen that through the years of rigorous schooling that we've all had, and we've been challenged numerous times in our struggle to get to residency. I've already learned so much in my 3 months of residency so far. I can confidently say that I've had a much deeper understanding of how to help our patients and provide excellent care. With this in mind, I would just like another opportunity to demonstrate my growth and our growths in November. Thank you so much for your consideration.
Thank you for the comments.
All right, this is the moderator. I'm not seeing any more raised hands, so Mr. Board President, I return the floor back to you.
Thank you, members. Bring back the discussion to you all. Any thoughts, comments?
This is Jesse. I mean, I would like to see that at a future agenda item, although I'm not sure time-wise if that will really address the issue at hand. And maybe a full board meeting would be more appropriate. I don't know if you have an opinion on which meeting would be most appropriate.
Yeah, it's such a sensitive item, so I'm gonna probably have Ann or Debbie, probably Ann, speak on that. Ann, do you have any comments on that item?
Yeah, so I guess what I'll just say is that the item is not agendized, so we can't really discuss it, but I'm happy to report back at the November meeting where we can maybe discuss it as part of the EO report or something. We do set the schedules, in advance, and we do try to be mindful of the 45 days. We'll also if the 3 commenters could please email me directly so that we can do a little bit of research on our end for them as well. Thank you.
Thank you. Appreciate that, Ann. Oh, sorry, Trevor. I thought you had a comment, but I'm gonna. Are you good?
Yes, I'm good. I'm grateful for Ann's follow-up with the individuals, and Jesse covered what I was going to say.
Thank you. All right. Any other member comments? Okay, we're ready to move on. Next, agenda item 3, approval of July 19th and September 4th committee meeting minutes. As we begin our consideration, I'll ask members if you have any questions or concerns or comments on the draft minutes for July 19th, 2024 licensing committee meeting. Also entertain a motion to approve if you believe such action is appropriate. Members?
I move to approve the minutes.
Thank you, Trevor. Any second?
This is Jesse. I'll second that.
Thank you, Jesse. We're ready for public comment. Public comment in Sacramento? Public comment in WebEx?
All right, I have opened up the Q&A panel. If any member of the public would like to comment on agenda item 3, the approval of the minutes, please either raise your hand or type comment using the field in the lower right-hand corner of the screen. Again, this is only comments for agenda item 3. We'll give you a moment. All right, I am not seeing any requests for comment. Mr. Board President, I return the floor back to you.
Thank you. With the motion and second, waiting for a vote. Trevor, how do you vote?
Yes.
Thank you, Trevor. Renee?
Yes.
Thank you, Jesse.
Yes.
Thank you, Satinder.
Yes.
Thank you, and I vote yes. The motion passes. Next is draft minutes from the September 4th, 2024 meeting. Members, do you have any questions or comments on the draft minutes? We'll also need a motion to approve if you believe such action is appropriate. Members?
Hi, Sung. This is Jessie. I do have clarification that I'm requesting on page 7 of 9. The paragraph beginning, a member continued to be hesitant. I just wanted to make sure that there was language added that we haven't made it through a flu or COVID season to see how the new laws have impacted working conditions in a retail chain setting.
Gotcha. Okay. With
Uh,
that, would you like to make a motion, Jesse?
yes.
Thank you. Anne, you got that comment, right?
Yes, and the beauty of the WebEx is we will have it that we can refer back to.
Everything we say is recorded for perpetuity. So that seems to be true for anything and anywhere in life these days. So all right, Jesse, any second?
Second.
Thank you, Trevor. Appreciate it. With that, ready for public comment in person? I'm sorry, it's a tiny screen on my end over there in Sacramento. So just if you are hoping to make a comment, just raise your hand and then come on over, okay? Just raise your hand for me if you have something to say. Thank you. All righty, and then we're ready for public comment in WebEx.
All right, I have opened up the Q&A panel, and if members of the public would like to comment on agenda item 4, another, or excuse me, on this other approval minutes, please either raise your hand or type comment using the field in the lower right-hand corner of your screen, and we will give you a moment. All right, I'm seeing no requests for comments, so Mr. Board President, I return the floor back to you.
Thank you, Tricia. With that, with the motion and public comment, we're ready for a vote. Trevor?
Yes.
Thank you, Trevor. Renee?
Yes.
Thank you, Jesse.
Yes.
Thank you, Satinder.
Yes.
Thank you, and I vote yes, motion passes. Next item is agenda item 4, presentation by the California Pharmacists Association on Assembly Bill 317, Weber, Chapter 322, Statutes of 2023 related to pharmacist service coverage. As included in the meeting materials, Assembly Bill 317 established requirements for healthcare service plan and certain disability insurers to pay or reimburse the cost of services performed by a pharmacist under specified conditions. I'm pleased to welcome Susan Bonilla, CEO of the California Pharmacists Association, Dr. Stephen Chan, PharmD, and Dr. Kevin Komodo, PharmD, to provide a presentation on implementation of the provisions. We are so happy you're here. I know that they did the audio and video testing already, so I believe you are ready to go. So the floor is yours, Dr. Chen and Dr. Komodo, and Susan, if you're also here as well. I don't know if Susan's here or if she needs to be promoted as a panelist. Susan, I don't see her, so she might not be.
Sorry, Chairperson Sung, I just wanted to let everyone know for the record that I'll be hopping off briefly, but I will announce when I'm back.
Okay, thank you, Jesse.
Thank you.
Thank you for the introduction and for this opportunity to share this update on where we're at with implementation of this law. I believe Sean Kim from CPHA is sitting in the audience. He's very small. Yes, that's him. Okay. Can we advance to the next slide, please? And this is just our disclaimer. And I believe you can skip the next 2 slides, which are introducing myself and Dr. Komodo. Thank you. Thanks very much. Okay, so we're, again, very happy to share this information with the board. This is an update, not just on the law itself, which I think everyone understands fairly well, but also on the process of developing some implementation guidance for health plans and pharmacists that started back in December of last year. We're going to go through that process, cover what is now in those implementation guidelines that were produced and in the form of FAQs, and talk about what's next in terms of steps. Next slide, please. So for background, and for some reason, I'm seeing very little of this screen, but I'll try to move it a little bit. There we go. For background, again, Dr. O just covered this. This AB 317 is essentially a payment parity law. It requires that health plans pay pharmacists providing services in community pharmacies within scope of practice that they would otherwise pay a nurse practitioner, PA, or physician to provide. Pretty much the core of it. Next slide, please. Now, in terms of implementation, when this law was signed, we were very excited about it, of course. Reached out to Susan Bonilla and just tried to find out, where we were at in terms of the plans and the readiness. And so we decided to do a little exploring. And we found is that other states that have tried to implement these payment parity laws ran into a few consistent issues. One is credentialing, the fact that pharmacists are just not accustomed to what credentialing really is, and oftentimes that's a barrier to getting going. The second is patient care referral and coordination, especially if you're in a pharmacy, which is separated from a clinic or a hospital outpatient building. That whole process can be quite fragmented. And third is medical billing. We're talking about a medical service and something that typically falls under the medical bucket in terms of funding, which is billed very differently than pharmacy. These were identified as key barriers. So we decided to host a focus group back in December of last year, consisting of a handful of health plans. And we just wanted to find out where are you at in terms of implementing or preparing to implement this law. And we found that there was quite a bit of inconsistency in how even the payers read the bill and interpreted it, and many what if questions. What if in this circumstance where we have this kind of contract, how would that work? And we decided it would probably be a good idea if we can to pull off some kind of guideline to help the plans and pharmacists understand how this law works. That last bullet point I think is really important. Washington State signed into law their payment parity bill back in 2015. We're now almost 10 years later. And if you ask them the question, where are you in terms of having community pharmacists participate in this? They're essentially nowhere. All of the gains that they've seen in their payment parity law have happened in the integrated setting with pharmacists and ambulatory care type of clinics. There's been a quadrupling of pharmacists. In the outpatient side, they've not gotten very far at all. So with that in mind, next slide, please. We really don't want to be 10 years later saying the same thing. So again, we decided to come up with an implementation work group to prepare guidance for pharmacists and for health plans on how to implement this law. Now, to be clear, this work group was not charged by any government office. We did communicate with the California Association of Health Plans. We did talk about our intent to do this, and their response was, well, we can't officially charge you to do this because it wasn't part of the law, but we would love if you would do this. So we kind of got the stealthy, unofficial, go ahead and do this. And then through California Pharmacists Association and their remarkable relationship with the California Association of Health Plans, we were able to engage their leadership and in turn engage all the health plans in the state. So as you can see below, the stakeholders that are part of this guideline production included everyone I just mentioned: pharmacists, health plans, primary care physicians, healthcare leadership, health system leadership, and then our own California Right Meds Collaborative, which partners health plans with community pharmacies. Next slide, please. So again, our deliverables were the two in the middle, probably the most important: the health plan implementation recommendations and expectations for pharmacists and other providers. We did have a level set document we produced for definitions and FAQs, and we're still working on the info sheet and FAQs for the public. I think this is really important, right, to make sure the public understands what is this law, how can you benefit from it, and how do you access this care. Next slide, please. So I'm going to go through some of the key components of the guidelines through FAQs, things that I think would be most of interest to you. So naturally, we have kind of a level setting of the purpose of the law in the guidance documents, and the clarification that this excludes Medicare and ERISA plans, right? States are unable to modify those benefits. Because this refers to pharmacy scope of practice, we make sure the pharmacists and plans are aware of where that reference is. And then the third bullet point, really important, does payment under this law prohibit health plans from paying for medical services outside of an outpatient pharmacy. This law is very specifically worded, as you know, in reference to outpatient pharmacy. And we were able to get clarification from the Department of Managed Healthcare that the law neither specifies or prohibits such payments if they're, for example, to be paid out of medical clinics or hospital-based clinics. What that means is if health plans choose to, they can apply this to paying for pharmacy services in other settings. Next slide, please. Next question is, does this legislation apply to services that are covered in a patient's medical or pharmacy benefit? This was such a major question to start off with. And the consensus from the health plans was that this is mostly a medical benefit. And why is that? Because it's a medical service. They need to map those payments to the right cost centers. They need to be able to check eligibility, clarify co-payments, all these things that happen under the medical bucket of funding. Now, services that are under a pharmacy drug benefit won't be touched. They'll continue as is. But most plans agreed and felt that this needed to be a medical benefit, and thus the importance of pharmacists getting familiar with medical billing. Now, what if you have a service being provided to a patient that's a pharmacy drug benefit service, along with an eligible AB 317 service? Do you bill for both? The health plans agreed and concurred that you would not, because in most cases, you would bill the 317 service and include that drug benefit service. And the example that we were discussing was, say, a patient during a 317 clinical service is identified as needing an immunization. You would provide that immunization and bill only under one provider visit under 317. Then the last question is, some of the plans sort of challenge that idea of this being a medical benefit. And they said, look, we want to reserve the right to be able to provide and pay for some of these services through the pharmacy benefit, through the PBM, for example. So there probably will be some plans that will still use some PBM pharmacy funding payment to cover the AB 317 services. Next slide, please. And what about credentialing and privileging? This is, as I identified in other states, a big, I wouldn't say a barrier, but a challenge for pharmacists who traditionally have not been credentialed and privileged. So to be clear, whether or not certifications or credentialing are required by pharmacists to be able to provide medical billing is solely at the discretion of individual health plans. There's no blanket, all plans have to do this, for example. And what do we mean by credentials? They could be specific licensures, such as APP. They could be residency training. It could be certifications, specific training specific to conditions. There's a whole host of things that could be considered in this. Next slide, please. And so just to give some clarification as to what we're talking about in terms of credentialing and privileging, I have this graphic that I hope makes very clear the differences. Obviously, scope of practice is under your purview. This is your authority. We're not talking about scope of practice here. When it comes to credentialing, it answers the question, what am I qualified to do? And this is under the authority of health plans and health systems. Privileging, which answers the question, what can I actually do in this facility, is purely under the health system. So bottom line is the health plans are looking at credentialing, whereas health systems can do credentialing and privileging. Next slide, please. So let's kind of answer a question that kept popping up quite a bit. Is some kind of board certification or APP licensure going to become a universal standard? And again, the plans are very clear. This is not going to be something that we're going to make uniform across the board. And in fact, I was actually somewhat pleasantly surprised to see that the plans were in agreement that for many services, they didn't think credentialing was necessary. Things that they expected pharmacists to be quite proficient at already, such as PEP and PrEP, which is obviously very important right now. Next slide, please. So are pharmacists going to be considered primary care or specialty? And the bottom line on that one is each plan, again, will be able to make that determination using national standards, CMS standards, et cetera. But in terms of specialty, there was some talk about how they would handle that. So what are examples of that? Oncology, cardiology, transplant, you can put psychiatry in there. These are services that typically would require some kind of advanced training. So the plans are thinking that for specialty type of designations, there's probably going to be some credentialing requirements in order for pharmacists to be paid for those services. And in the end, whether it's primary care or specialty, will have some copay implications. Next slide, please. This is, sorry, preaching to the choir, but we did want to make the clarification, especially to pharmacists and payers as well, as to what we're talking about when we say collaborative practice agreement. The plans felt pretty strongly that for the more longitudinal type of services like comprehensive medication management, that these should ideally be performed with some kind of CPA in place. So to be clear, we're not talking protocol where things are very algorithm driven, step by step, and it's very difficult to step outside of that algorithm. We're not really talking about a blend of a CPA and a protocol. We're talking about pure CPA, which today tends to be much more permission based versus algorithm based. So it basically states this is what the pharmacist can do versus this is what a pharmacist will do, step A, step B, step C, etc. Next slide, please.
So
I think Kevin. Yep.
Oh, yep. Great.
Yep.
Continuing on with the FAQ, one of the next questions that came up was about place of service. As AB 317 really focused on the community pharmacy setting, the obvious answer is place of service is the pharmacy. With that stated, we had some very interesting discussion that came afterwards about some of the unique places that patients were serving. But let's look at the pharmacy first. Within the pharmacy, one of the big distinctions, and this is pretty obvious, I'm sure, to the board, is that these activities are separate from the pharmacy consultation. The pharmacy is responsible for the pharmacy consultation. These do not overlap. This is a completely separate service that is in line with what the code is that you would be billing for, or what type of service you would be providing in any other setting. As such, within the pharmacy, there needs to be the appropriate types of space to be able to provide that type of patient care. Some of the not expected things that we got out of this were the non-traditional ways in which people have pharmacies that are integrated with health systems, hospitals, and are providing programs like transitions of care or providing different types of clinic support services from the pharmacy, maybe with integrated pharmacists. In those types of settings, the place of service may change. But once again, getting to the theme that Steve was mentioning, as far as how that will be billed or how the place of service will be documented on the actual billing, that needs to be done in conjunction with the health plan because there might be different requirements based on one health plan versus another. Next slide, please. The next question is a diagnosis required for billing of services? The great part about this is we don't have to reinvent the wheel. These practice standards are already set for medical billing. So if a pharmacist is seeing a patient for some sort of a clinical service, there should be a diagnosis code associated with that service. There are situations where pharmacists might be working with a patient for preventative care. And in those cases, the standard already exists for that as well. ICD-10Z series codes can be used for identification of those services. Next slide, please. All right, so what about CPT and HCPCS codes? So what should we be anticipating for billing? This was a tricky discussion. And at the end of the day, the health plans didn't want to give that level of granularity. And this actually ends up being a good thing. Hypothetically, all codes that are available to any practitioner are also open up to pharmacists as long as they meet the qualifications to deliver that service. What's most likely going to come to the top? It's going to be things like E&M, possibly MTM. So E&M is evaluation and management. I'm sure a lot of you know that. Tests, lab tests, telemedicine, things like that. But the fact that we have now the entire book open actually provides a lot of flexibility for pharmacists to really think about how they're going to address emergent public health issues. Steve brought up a great example, which was HIV, PEP, and PrEP within the community pharmacy setting, and actually just pharmacy as a whole. We've been struggling to figure out how you deploy these types of services in a sustainable manner. AB 317 could create the ability for us to be able to do things like that. As a aside, regarding existing pieces of legislation like AB 1114, those types of things would continue to be processed in the manner in which they've been processed before. So this doesn't really affect that. Also, Steve alluded to what if there's discrepancies between the medical benefit and drug benefit. So those will kind of come up on a plan by plan basis, but the big theme is there should only be one billing for that service. Just to finish up this conversation about CPT and HCPCS codes, Washington State actually worked with AMA. ICD-10s are actually copyrighted, so you have to pay for the copyright to be able to use it. Washington State actually did create a handbook for trying to map certain pharmacy services to ICD-10 codes. So if anybody's wanting to look at that, you can feel free to reach out for that resource. Next slide, please. All right, will contracting be required for AB 317 services? This response actually surprised me, but the response actually varied from plan to plan as well. I want to make a quick distinction. There are two topics at play here. One is pharmacy networks, and the other one is about pharmacy contracting. To provide the services, the health plans will be required to create pharmacy networks. But whether or not they support that service, the clinical services with having a contract that explicitly states those things, that's going to vary plan by plan. So some of the benefits of having a contract is that it much more explicitly will define what are the reporting requirements, documentation requirements, which codes are eligible, which are not. But it doesn't necessarily have to be defined. That really was a surprise. Once again, this is something that will need to be worked with on a plan-by-plan basis. Next slide, please. Other things that need to be clarified, Steve covered the first one, which is that Medicare and ERISA plan, so the Employee Retirement Income Security Act. Those do not qualify as those are federal programs. AB 317 being a state legislation would not apply to those. Also, it does not apply to Medicare MTM in a similar fashion. However, other types of MTM programs may be eligible for AB 317 services based on if a plan chooses to adopt it. Next slide, please. All right, so next steps. I'm going to kind of take a little step back out of here and just say, you know, we have an exciting piece of legislation which recognizes pharmacists that are providing the same type of services and level of care as other types of providers. As we're looking towards the future, one of the big things is going to be about continuing to work on these documents. This is the base for the like kind of coming up with what are the best practices from the health plan's perspective. But as we learn more, things are going to change. So we'll continue to have these conversations with CAP. We have a wonderful group of people that have been involved in this process. And as those discussions change, so too should the documents. Those will be living documents, which continue to evolve as our understanding of AB 317 implementation evolves. Switching from the plans and now looking at the pharmacy community, there's a lot of things that need to be worked on. We actually have we have a really good group of people spread throughout the state that are already doing these types of things, but that needs to make its way to the rest of the profession. So there needs to be education and work groups to discuss workflows, documentation, billing, and best practices overall. Stepping outside of the mechanical, one of the things that we need to also do as a pharmacy community is we need to create a culture of implementing pharmacist-led, community-focused clinical services. Pharmacy has a history of being able to address public health needs and deploying them in a way to be able to address major issues. A great example is the pandemic and the mobilization of vaccinations. Also things like looking at opioid overdosing and issues with gaps in care for women's health. HIV, PEP, and PrEP is one of the things that comes to front of mind for me. And also like readmission prevention. So there are so many ways that we can do this, but once again, within the community, creating that culture of actually it's perpetuating the culture of pharmacy being the answer to a lot of public health issues. If we do AB 317 right and we work with the plans to implement it correctly, I foresee the profession really helping to step up and address those needs. Next slide, please. All right, so having a plan is great. Steve's alluded to this a little bit, but when we look at where it is that we need to implement it, we need to make sure that health plans are on board, pharmacists and pharmacies are on board, clinics and health systems, as well as the general public. In the past, we've already worked with CAP. The California Pharmacists Association has also held town halls, but we've worked with other associations within the state to spread those documents. We're also working with the schools of pharmacy. I am being here today with the Board of Pharmacy and having you guys hearing about this. I think it's wonderful that the entire community is coming together for this. We've also worked with the clinics and health systems. So thank you to Dr. Buss and then also Dr. Rita Shane and Dr. Steve Chen, who've been a crucial part of this whole group, ensuring that we're working with groups like the California Right Meds, the California Hospital Association, as well as CMA. The public-facing piece will come in the future. Those are some things we're working on smaller scales, but we hope that as these services become more available, that the patients, especially as we're aligning that with public health needs, learn about these services. Next slide, please. This is just a shout out to some of the members of the AB 317 subgroup. Really wanted to thank them all for their efforts. They come from a lot of different places, including managed care, practitioners and health systems, just a wonderful group to work with. And with that, next slide, and I'm going to hand it back over to Steve for some final thoughts.
Thank you, Kevin. I just wanted to leave the board with this quote. This is from a physician leader who sat on our implementation guidance committee. It needs to be read verbatim. Significant evidence demonstrates positive outcomes when pharmacists provide patient care services. In alignment with the intent of the AB 317 payment parity law, payers support the inclusion of pharmacists in their health plan provider networks to bill for covered patient care services within the pharmacist scope of practice in the same way other providers such as physicians, NPs, and PAs are included. This in turn will remove the historical barrier for pharmacists to provide and bill for covered patient care services necessary to improve clinical and health outcomes, increase access to care, and optimize the effectiveness of care teams. I've been a pharmacist for 35 years. I've never heard a physician come up with this kind of wording in support of the value and importance of pharmacists in the healthcare system. I will tell you that this physician was so passionate about including this wording that she rebuffed every attempt from the health plans to edit anything that she wrote. It was really impressive. This physician also is a prominent leader in the California Medical Association. So I just want to share with the board that really at the highest levels, medical leadership is behind this and wants to see this leverage for the benefit of patients and for the benefit of physicians as well. And I think that we have a Q&A after this, I believe. Thank you.
Thank you so much, guys. Thank you. Appreciate your time. And I have quite a few questions. I'll start if that's okay. And so for just global statement, I think that with this and with hopefully standard of care, I think there's quite a bit of a huge opportunity in the future, hopefully for pharmacist services that could help and positively impact patient care. And it's very exciting to hear this. I know it's early. I know it's been everything moves a little slower than we hope. First question I have is about the HMO implications, and if you guys had any luck in trying to figure out how that could be worked out. And I do see actually this as somewhat of an opportunity with maybe a capitation. A pharmacist could kind of form some sort of an HMO network in that neighborhood and conjoining, not as competitors, but as a collaborators in trying to provide pharmacist-driven care. Just wondering if you guys had any opportunities to see if there's any, any solid kind of tracking on getting that going or any opportunities?
Well, President O, you have picked on the one area of greatest challenge for the health plans. So they immediately identified these particular contracts, whether it be capitation or per diem rates, as being kind of the challenge for them. Because as you're implying here, they have certain agreements with facilities where, in essence, in many cases, they're capped. So if a capitated facility wants to provide services in partnership with a community pharmacist under AB 317, at least at the moment, the response from the payers is, well, that's great, except we're already paying this facility for all the services. If anybody needs to pay for these, it'll be the facility. So that is a challenge without question, and something that they are well aware of that they have to figure out. No answers that we've heard yet to resolve that. Kevin, is there anything else that you've heard or that you want to add to that?
No, that's right in line with it. And I think that's one of the big challenges that we're going to see right now is because within California, especially, there's such an interesting fragmentation of like how medical benefits are provided, some at cap, some fee for service. And so I think that as we go through this, part of the education that needs to go to pharmacists also is how to understand the American healthcare system, because we can't go in with the expectation that we're going to submit some claims and be paid. You have to understand the benefit structure, who's responsible, and ensuring that you're providing service in contract with the appropriate entity.
Gotcha. Yeah, California has a huge HMO history and, population, as well as I think that increases. I mean, hopefully Medicare one day that could resolve some of that challenges if that ever happens. But, that's a story for another day. Next question is about the EMR. Is there any opportunities for California Pharmacists Associations to provide some support and guidance for EMRs? Because I think that will be, pharmacy dispensing softwares, I don't think is able to really handle the kind of clinical services that will be expectations for patient care. So are there any opportunities? I know Epic is out there, but there's, hopefully, is there any working with California Pharmacists Association in kind of providing pharmacies with the directions?
Kevin, you want to take that?
Yep. So there is an emergent market for electronic medical record organizations that are a little bit more pharmacy focused. Obviously, like as we're working with this type of patient population, having tools that specifically allow us to be able to do pharmacist related work and to help to facilitate some of the analysis that we'd be performing is preferred. Right now, there are handfuls of people that have entered the space. And so actually with the association, one of the things we're doing is trying to establish relationships with different groups, get to understand them, and then to make sure that there's a pipeline so that way our membership can have access to them and to determine what's most appropriate. Some within the community pharmacy setting, there are some groups that pharmacy management systems that are trying to integrate their own medical record systems to varying levels of success. We think that the best thing that's out there is if there are those options, that there's also third-party options as well. So really just trying to bring it all together. I haven't seen too many people outside of a clinic setting where they're already on like one of the larger systems like Epic or Cerner using those systems. I do think that's still going to be part of the future, just as you're looking at integrated models. But we're really hoping to see more of that emergence too of that third party as well, because pharmacists will require pharmacist-specific tools as well. Steve, did you have more on that one?
No, I mean, well said. I believe there was just literally a handful that have figured out how to enable exchange of health information, how to integrate and manage medical billing within those practice management platforms that Kevin referred to. So we are very actively engaged in speaking to a couple of companies that seem to be willing to provide some kind of a discounted rate to pharmacists in California that are working in partnership with CPHA.
Thank you. And one last question, and then is just about consultations. I do believe, obviously pharmacists should be providing consultations, but I'm hoping that there will be an opportunity for advanced consultation, which you could call that an MTM, but I think I'm hopeful that, I guess this is more of a statement. I'm hoping that there can be some avenues where a patient asking for a further thorough consultation, if they're part of the network, that they can one day, we could actually, bill for and possibly, have a reimbursement for consultation services that, are advanced consultation, complex medication use. And I think ultimately, hopefully there's an opportunity for a staying away from pharmacies making money only by filling medications, but by actually taking people off of medications by consultations and reducing polypharmacy issues, which I mean, we've all deal with every day, especially for patients. I mean, unfortunately, those folks most likely is in Medicare, but hopefully that there's an opportunity for.
If I can comment on this, you're actually hitting on like one of the areas that I find extremely exciting, like and Steve too. And actually, like, right now there are certain types of emergent models that are out there, like DHCS's MTM program, that only affects a certain level, a certain cohort of patients. Steve's California Right Meds program is working with a specific cohort of patients. And there are definite clinical benefits to those patients. In my area of the state where we're working with rural patients, a lot of them face a lot of issues with definitely polypharmacy, diabetes management, asthma management, and there's way more that needs to be addressed than what you can accomplish in a consultation, because it requires a thorough drug review. And we found great success so far in being able to implement those, but it's very small scale and it's only a very specific cohort of patients. So this is just very, very exciting if we could find out how it is we do this, because you have a very accessible location that is, independent of the existing medical system. Anybody can walk into the pharmacy. And if they have the methods to be able to bill it, they can get access right there that is complementary to the medical care that they're receiving through their physician. So just very exciting.
Maybe the other, and that I fully agree. The other element I'll add is, as you know, DHCS is supporting payment for community health worker services. And we have a conversation today with DHCS to talk about our program, which certifies pharmacy technicians to provide CHW services. So the implication here is now a patient can come in and yes, because of the laws that we're sharing here in these policies, they can get pharmacist expertise in managing and troubleshooting these issues they're having. But they can also now have a pharmacy technician serving as a CHW, providing social support services, identifying their needs, identifying resources that can benefit them, providing patient care coordination, and then all gets billed to a separate bucket. So really a unprecedented time for community pharmacy to be an agent of change in terms of health and social support.
I really do hope so. I do have Jessie trying to join. So Jessie, if you could promote her, please, Trisha. And I'll go to next to Tinder. But in closing, I talk enough, so I'm gonna stop talking so much. But I really am excited about this. I really am hopeful that this is a opportunity to revolutionize pharmacist-driven care, where people can get better care. I know pharmacists has many unique knowledges that are, I think, well beyond that could contribute in reducing healthcare costs, improving qualities. I do hope for pharmacist-driven clinics where pharmacists are working together to provide patient care one day that are going to be around the California and around the country in the coming decades. And I think that is necessary for us to really revolutionize care for people. So I appreciate your time. And Satinder, I'll go to you next.
Thank you so much, Dr. Thank you, Dr. Chen, and thank you, Dr. Kawamoto, for taking the time educating us. A question I had was, Dr. Chen, I think, brought up idea of one of the barriers being the medical billing, and I, being from community pharmacy, I think that's one of the biggest challenges. Some of the reasons that pharmacies are hesitant to provide these services because the medical billing is a whole new ball game, and also it's very clunky the way the systems that are available. Can you elaborate on that, if there's anything that's going on to advance that specific to pharmacy billing, not necessarily, all the bells and whistles that are needed for the healthcare systems, for example. And as we know, that healthcare systems invest millions of dollars, in their billing practices to make it efficient as possible. How could that be achieved at a community level? So if you can elaborate, that'd be great.
So a great question. So I'll preface my comments by saying I'm not endorsing any company that I name in the next few sentences here. But again, there are some companies that have gotten very far in creating very pharmacy-friendly platforms to conduct medical billing. One of them, for example, is DocStation, which we've spoken with. Many states are using DocStation in community pharmacies because they simplify the process of medical billing. They reconcile billing, they adjudicate billing. They do everything that you need in a way that's quite user-friendly, to your point. AssureCare, another company that we're looking at. There's another company that doesn't have a name yet that actually is very far along as well. So companies are recognizing the need for this. They're trying to make it very simple. Several companies have made it quite simple. So I think we're going to be able to facilitate relatively straightforward billing, the process at least from a technical side. Where I think the challenges lie, however, are going to be on the health plan side. We had a great conversation last week with a few health plans, and they're telling us, boy, we're really struggling with pharmacists that don't understand billing. They're sending us wrong codes. They're sending us wrong information. So it's going to be both sides, right? We could have the perfect platform, but if pharmacists aren't trained and knowledgeable on how to utilize it, you're still going to have trouble, right? So that in our collaborative, CalRightMeds, we have a component of training now where we teach pharmacists how to actually provide billing codes and billing processes in a way that plans will understand and pay for.
And to continue on with Steve's conversation too, you're right. There's the technological piece, but then there's also the knowledge piece later. So it's great that the health plans will be feeding in information. We talked about that living document. So as there's learnings from this process, that also makes its way into the California Pharmacists Association education. You actually hit on that this is probably going to be the core stumbling piece in the initial phases. And so ensuring that even when you have the platform, that you understand all the different fields that need to be populated, and each one's going to be different based on how contracts are cut with the plan. So understanding the nuances and how you document that.
Thank you.
Thank you, Satinder. Any other member comments, questions? Please feel free to jump in.
Sung, it's Jessie. I just wanted to note for the record that I am back. I know my video's been on, but
thank you. All right. Thank you, guys. I really appreciate your time. Thank you for coming. Thanks for providing information. And I'm sure this is not the last time. So we'll, I'm sure, hope to hear from some updates as the time goes on. Thank you. And just don't go yet. Don't go yet. Sorry, we have to go. As a public agency, the committee provides members of the public the opportunity to comment on each agenda item. This is not intended to be a question and answer, but rather an opportunity for members of the public to comment on the information discussed. At times, questions are asked, and you are under no obligation to respond, but if you would like, you can. So with that, we're ready for public comment in Sacramento. I think that's Dr. Sean Kim. So okay, he's good. So, and then we're ready for public comment in WebEx.
All right, I've opened up the Q&A panel. If any member of the public would like to make a comment on the presentation, please either raise your hand or type comment using the field in the lower right-hand corner of the screen. We are displaying instructions and we'll give you a moment. All right, I'm not seeing any raised hands or requests for comments. So, Mr. Board President, I return the floor back to you.
Thank you, Trisha. Thank you, guys. Really appreciate it. All righty, we're moving on. Thank you, guys. Have a good day. Moving on to next agenda item 5, discussion and consideration of proposed changes to board provided training for furnishing HIV pre-exposure and post-exposure prophylaxis as included in the meeting materials. Recent changes in California law have updated the provisions for pharmacists furnished HIV pre-exposure prophylaxis or PrEP. To address these changes, the board adopted emergency regulations. In addition, it is appropriate to update the board's training program to incorporate the changes in statutes as well as standards for pharmacists furnished HIV pre-exposure and post-exposure prophylaxis consistent with the statute. I'd like to thank all of the experts that have assisted the board with updating the training program, including Dr. Betty Dong, Dr. Clint Hopkins, experts with the Office of AIDS and Department of Healthcare Services. As indicated in the meeting materials, following approval by the board, Dr. Dong will finalize the program and quiz. The training will be deployed on the board's new learning management system. Members, the training program slides are included as attachment 2 to the meeting materials. I have reviewed the materials and believe they are appropriate. And as I open for member comments, I would also entertain a motion to recommend approval of the training program. Members, any comments or anyone would like to make a motion?
This is Jesse. I'll make the motion to approve the materials.
Thank you, Jesse. Any second for Jesse's motion?
This is Renee. I'll second that.
Thank you, Renee. Appreciate it. And any other member comments? Seeing none, we're ready for public comment in Sacramento. And we're ready for public comment. Thank you, Anne. We're ready for public comment at WebEx.
Thank you so much. I've opened up the Q&A panel. If any member of the public would like to comment on agenda item 5, please either raise your hand or type comment using the field in the lower right-hand corner of the screen. We are displaying instructions and we'll give you a moment. All right, I see no request for comment. Mr. Board President, I return the floor back to you.
Thank you, Tricia. With a motion and second and public comment, we're ready for a vote. Trevor, how do you vote?
Yes.
Thank you, Trevor. Renee?
Yes.
Thank you, Jesse.
Yes.
Thank you, Satinder.
Yes.
Thank you, and I vote yes. The motion passes. Next, agenda item 6 is discussion and consideration of proposed follow-up survey on working conditions. As you may recall that as part of the board's prior sunset review, the board committed to conducting a survey on working conditions in community pharmacies. The survey was conducted in 2021. Believe it or not, the data released in December of 2021. It appears appropriate to conduct a follow-up survey to gauge current working conditions and gain insights from pharmacists on the implementation of provisions including AB 1286 related to working conditions, as that bill became effective last year. So members, as I open for our discussion, I would welcome your thoughts on releasing an updated survey, as well as if you have any specific areas of AB 1286 you would like to add to the survey questions. I'm happy to report that experts within the DCA's Office of Professional Examination Services will again assist the board if we determine deployment of a survey again is appropriate, members. Trevor?
Yes, I absolutely fully support getting this survey out there. I think based on the analysis we've had at multiple meetings of the previous survey, which had really good response rate, I think the area everyone identified as a need for increasing responses are from non-managerial staff, making sure that pharmacists, pharmacy technicians, and not just pharmacists in charge and those in managerial positions are talked to, especially because so much of 1286 had to do with working conditions. We should be talking to the folks that it impacts the most, which are the workers, the pharmacists that are managed by pharmacists in charge, et cetera, et cetera. So my main request moving forward with what I think is a very necessary survey is to put added emphasis on all workers within pharmacies and not just those with managerial and oversight roles.
Thank you, Trevor. I'm sorry, I think I misspoke that it became effective last year, but it became effective this year. I feel like the time just flies by and it is hard to keep up with it. Jesse?
Thank you. I absolutely think another survey needs to be done. Now that we're really getting into the depth of flu and COVID season, I can say from personal experience and from hosting pharmacist calls across all of the companies represented at our union, which includes Rite Aid pharmacists, CVS pharmacists, Ralph's, Albertsons, Vons, Pavilions. We all are suffering from the same issues. And unfortunately, because it's so busy this time of year, pharmacists just can't participate at board meetings the way that they can at other times of the year. So doing a survey will really give us a better idea of what is actually going on in the pharmacies. I'm open also to opening it to pharmacy technicians as well. Sometimes the pharmacists are a little hesitant to complete surveys, so maybe opening it to technicians will give us a broader perspective of what's happening in the pharmacies. The other things that I want to note too, something that comes up often as an issue is PIC autonomy over scheduling under AB 1286. We really haven't discussed what specifically that means. I think there's a lack of understanding. And I'm hearing from a lot of PICs that they have zero autonomy over staffing decisions. The other thing that I think we need to look into is including questions about workload to staff ratio, whether they believe that the staffing is appropriate for the workload they have. Also just noting that AB 1286 addresses a minimum staffing requirement, but still doesn't address staffing models that exist in corporate chain settings. Unfortunately, everyone has their own algorithm for how they determine what the staffing level is, but I've had pharmacists tell me that they're doing over 300 prescriptions a day, 60 vaccine appointments, and they don't have control over the vaccine appointments. They really don't feel like they actually have the ability to turn people away. And then the other thing that I think we should consider looking into is compliance with quotas and SB 1442. I think with AB 1286 in place, 1442 has kind of been on the back burner for a lot of pharmacies. So taking a deep dive and seeing whether or not chains are actually complying with 1442 requirements, what that looks like. But I know that a lot of pharmacists are getting pressure, even if they're not given a specific number in terms of a quota. They're essentially being forced to go on extra conference calls, or they get calls or texts in the middle of the busiest times in the pharmacy asking why they haven't done more vaccines or more of a specific vaccine. And so I think we really need to get a really overview, a huge overview of what's actually happening. So I'll leave it at that because I know that was a lot.
No, Jesse, that's great. I do really agree with basically everything you said, but I think that the survey could be a little more, the data, at least analytics of it, could be granular in what the PIC says and ask them if they feel the autonomy. We could look at PIC and the pharmacists, rank and file pharmacists, and then and sometimes PIC are clumped together with the rank and file pharmacists in many settings, so they really don't have the autonomy, and that's the unfortunate issue. And then the technician, I really do agree. I think that this time it could be released to technicians and see what their thoughts are and what they see as an issue as well. And then quota for sure. I do think that that could be asked to everyone, including technicians as well. With that, Satinder, your thoughts?
First, I want to 100% agree with Member Carly. She brought up a lot of excellent points, and we do need another survey to assess how the implementation of the 1286 affected this, and especially the quotas that she talks about. My question was like, do you remember what time of the year the original survey was sent out? Because we would want to get my thinking was we want to send out the survey about similar time period to assess so we can compare apple to apples in some ways. So that, because there's obviously a fluctuations, as Member Crowley pointed out, right now is a very busy flu immunization season. So depending on, sometimes that recency effect that, what's fresh in your mind could be impacted by that. So maybe we want to think about it, that it's released during the similar time period to assess the similar conditions, although you can't exactly duplicate all the conditions. 2021 was totally different ball game than it is today in terms of immunizations, but as close we can. That's just all I had to say.
Thank you, Satinder. That's actually a really good point. I think it actually was around October of 2021. But Anne probably can recall better than I can. I cannot believe it's been almost 3 years since this was going on. But while Anne, you can try to see, and I'll go to Renee, and then we'll get back to you. Renee?
Hi, yes, in agreement with all the other board member statements. I was also wondering, just in terms of the release of the survey. So, I would agree timing, perhaps the same for comparison, but I just don't remember, since I wasn't around at that time, but like if we want to look at increasing the duration for responses, I don't know, like we could talk about the pros and cons of that, but possibly that. And then also if we could look at how did we kind of advertise, if you will, to please complete the survey. And, it just obviously by hearing this, pharmacy conditions, busy, checking emails, probably not a lot of time, responding to a survey that might take a few minutes, also not a lot of time, but just really making sure to make it as accessible to encourage those responses as possible. I'm not saying it was too small last time, but just thinking about that. If the time period starts to be now, when we know it is so busy already and it's not going to slow down for a while, or doesn't really slow down, but just to keep those factors in mind to see how we can optimize responses.
Thank you, Renee. All right. And were you able to find out when it was released? If not, I mean, I think.
Sorry, I am checking now, but I would say that we can like totally try to do it at the same time, but I do think that in 2021, I wouldn't, there was a lot happening in terms of COVID. So the workload in 2021, might, I don't know, right, looking at like the immunizations and all of that from 2021 is what was happening at the time of that, which I believe was late summer, early fall, but I will totally get those dates. Would that be similar to what pharmacists are experiencing now?
Okay. Okay, thank you, Anne. I think that we'll just have to be as close as we can, trying to. So, okay. All righty, members. Any other comments before I open up for public comments? Okay, ready for public comment in Sacramento?
We do have comment in Sacramento. Thank you.
Okay, thanks, Anne.
Thank you, members and President O. I was just wondering, what would be the purpose, what would be the goal of this additional survey? You're trying to compare to the previous law passing to what it is now?
Thanks for the comment, Sean. This is not a question and answer session, but I will, in respect of your question, I will address, I think, as stated in the opening statement, yes, the goal would be to try to see if there's been some improvements with the law in place, if pharmacists feels a little bit more, I would say pharmacist feels a little bit more autonomy or whatever else that may be going on. We're trying to see if that made any improvements.
Thank you.
Any other comments for me, Sean? Just question?
When we try to compare one to another, I think it'll be nice to have the similar questions if we want to add additional questions like technicians as well. But I just want to make sure that if we are comparing it A to B, it is similar type of questions.
Okay. Thank you for your comments. All right, with that, we're ready for public comment in WebEx.
All right, I've opened up the Q&A panel. If any member of the public would like to comment on agenda item 6, you can raise your hand or use the text box in the lower right-hand corner. I do see we already have some raised hands, so we will start with Jazzy Gruel. And Jassy, you should be able to unmute yourself. There you go.
Good morning. This is Jassy Graywall on behalf of UFCW Western States Council to speak in support of this item. We think an update on the workforce study would be great to be able to hear directly from pharmacists and pharmacy members behind the counter to share what their experience is like with staffing. Additionally, we've had laws in place for a couple years now, excluding 1286 that just went into place this year, but to be able to track their implementation and effectiveness, I think is really important going into the sunset review process next year. A couple comments I specifically wanted to make is that it would be great to have a focus in the survey on the PIC and pharmacist on duty staffing autonomy that is prescribed under section 4113. We have heard significant concerns by member pharmacists being able to utilize this and to the extent in which they can utilize it. We've heard that pharmacists have requested additional staffing, have been rejected, or what happens is they'll get staffing for that week, but then a significant hours cut in the weeks after. So it'd be really great to be able to understand this. And I think what we have heard from members is what is the process to even be able to request staffing, and what happens if the company denies that staffing request, sort of what is their recourse in that process. Additionally, it would be really great to be able to get more data from pharmacy staff on staffing required under 4113.6. This is the no pharmacist left alone provisions to make sure that a pharmacist is staffed at all times with a clerk or a technician. We are starting to hear that clerk and technician support is being pulled off or being pulled out of the pharmacy, and that some companies are saying as long as there's a manager in the front of the store, that is sufficient. Additionally, we think that this is a great venue, this survey, to be able to share information with pharmacists about all the bills that have been passed in the past few sessions, but also a way to share with pharmacists their protections against retaliation when coming forward with a complaint. We also hear concerns from pharmacists about not even knowing how to file a complaint with the board. So if there's a way to also share information with pharmacists and pharmacy staff on the process, how to collect data and evidence and what documentation should be when filing a complaint, that would be a great venue to be able to share that information with pharmacy staff. I shared a lot there, but happy to elaborate more at a future time, but thank you for allowing me to make comment.
Thanks for the comment, Jassy.
All right, next we have Stephen Gray, and Stephen, you should be able to unmute yourself. There you go.
I really appreciate the willingness and the board to do another survey. I think it's completely appropriate. And probably as a matter of course and tradition, follow-up surveys when there's been a major law change are really important to see what effect they had and whether any adjustments need to be made. So I think this is a really good idea. I also want to comment that the timing is right. As Jesse indicated, this is the time for more immunizations. And many people maybe on the call don't realize there is a substantial outbreak of new COVID, a new strain of COVID in Oregon and in Washington. Not much in California yet, but we can certainly expect it to be coming our way. The sooner we can get out there and be in sync with a upsurge in COVID immunization requests, that would probably most mirror when the survey was done last time. So I also agree that with Jazzy in that there is a confusion about what AB 1286, I may get that number wrong, 1286 law change did to section 4113.6. There's confusion about those two bills and what they do and how they work together. And some managers that I've talked to have said, well, the later bill negates what was done in 4113.6. So I think that the survey and the educational materials that she mentioned are always important. There are a lot of new pharmacists out there. I teach at UCSD, and there are a lot of graduates who end up becoming PICs as soon as they graduate, and they do not have enough information and experience to understand all these subtleties. Thank you for the opportunity to discuss this.
Thank you for the comments, Dr. Gray. Appreciate it.
All right, this is a moderator. I see no further requests for comments. So, Mr. Board President, I return the floor back to you.
Thank you, Tricia. I believe for the record, the survey released around May 7th of 2021. Survey was released and then it closed around June 7th of 2021. And I do want to remind that there is a wonderful FAQ that we created for AB 1286 that addresses some of the concerns that I heard, especially the one that Dr. Gray mentioned and Jazzy mentioned about 4116, about the staffing requirements. And it actually, I thought it pretty clearly lays out that, that law is not, it does not negate the current regulation about pharmacy staffing, and that pharmacists, someone must be available to assist within certain time period if they're working alone in certain conditions. Yes, the laws are so complicated, as I just to say that alone is a long statement anyway. So I just think that the FAQs, if you do come across anyone, please refer them to the board's FAQ on that section, because it does clearly explain that, I think, in my opinion. Jesse, your comments?
Yes, thank you. I just wanted to agree with Dr. Gray's comment in terms of the timing. 2021 isn't a normal year, of course. If I remember correctly, the vaccine became available sometime around December to January of 2020 to 2021. Maybe I'm remembering that incorrectly. But I think peak flu season is really where we're going to see what the effects of AB 1286 have had, if any, on current working conditions. That's really the most critical time. That's when we need the most staffing and the most support and the most autonomy. And so I think now is really the time to release the survey.
Thank you, Jesse. Okay, members, any other comments? And so I'm going to call you out, and I'm sorry to put you on the spot, but I think you're used to it by now. Do we need the board motion as a board to release survey, or do you think at the committee level we could do this and release it? I guess this is more of a council question for Corinne, but.
Hi, this is Corinne. Um, I mean, I always say, in doubt, do a motion. So it probably, I mean, there is a board meeting coming up, so that would
But I
probably be
think
my
that
recommendation.
should we wait to have the survey? I'm guessing, okay, well, we should probably, just trying to see how fast we can do this is what I'm trying to get at.
So if the committee is agreeable, maybe, so sorry, was doing a couple of things, but it sounds to me like we're going to be using the prior survey, but potentially adding some additional questions on. And
Right.
then developing a survey for the technicians, because some of the questions, right, might need to be changed to make
Yep.
them technician focused. So if members feel comfortable with this approach, I'm happy to work with Sung before the board meeting, and then we can present the draft surveys to make sure that members feel comfortable with them. And then we can finalize if we don't have a chance beforehand with OPES to make sure our questions are, survey appropriate kind of thing. So if that approach sounds good to members, that might be a path forward.
Members? Thumbs up or, yep, okay.
That sounds good to me. And so if we wanted a motion for the record, I will make the motion to approve the survey and allow President O to work with and to develop the questions consistent with our discussion.
Sounds good. Any second for the motion?
I'll second that.
Thank you, Renee. Appreciate it. With that, we're going to open up for public comment in Sacramento. Any public comment in WebEx?
Thank you so much. I've opened up the Q&A panel. If any member of the public would like to comment, please either raise your hand or type comment using the field in the lower right-hand corner of the screen. We are displaying instructions and we'll give you a moment. All right, this is a moderator. I see no requests for comment at this time. Mr. Board President, I return the floor back to you.
Thank you, Tricia. With a motion, a second, and public comment, we are ready for a vote. Trevor, how do you vote?
Yes.
Thank you, Trevor. Renee?
Yes.
Thank you, Renee. Jesse?
Yes.
Thank you. Satinder?
Yes.
Thank you. And I vote yes. The motion passes. It is 10:24. I think it's opportune time for a quick 15-minute break. We'll come back at 10:40, everyone. 10:40 a.m. See you all soon. I think actually it's Renee. Renee?
Hi, yeah. Renee, the licensing member present.
Thanks, Renee. Jesse? Not yet. Satinder?
See member, yes, present.
Thank you. All right, just need Trevor or Jesse.
Hi,
There's
Sung.
Trevor.
This is
Hi,
Jesse.
Trevor. Hi, Jesse. Trevor, you back?
I am back.
Thank you. All right, we are back. Moving to next agenda item 7, presentation on changes to pharmacy application process. This next agenda item is a brief presentation on changes to the pharmacy application process. And the floor is yours. Thank you so much.
Hi, thank you. Emphasis on the brief, but we will make these slides available so people have the opportunity to reflect back to them. So if we can go to that next slide, please. So this one really just kind of lays out some of the relevant laws that people may want to consider as they're trying to understand a little bit more. If we can go to the next slide. So we have a lot of common deficiencies. And so really what the intent of us evaluating is trying to see if there are things that we can do within the application package to try to reduce the number of applications that we receive that are deficient. Because as we look at processing times and contributing factors, right, if we receive applications that are complete at the front end, we're only touching them once, and that's best for both the applicant as well as for the board, as we have limited resources. So some of the common deficiencies that are on this slide and the next, some of them really are just really in control of the applicant itself. So for example, missing fees, incomplete forms, we can try to provide clear instructions, but those are the kinds of things that people are probably going to have to self-manage a little bit. If we can go to the next slide. So you'll notice even things like, forms not being dated. The other kind of thing that we see is that sometimes the individuals that are completing the application forms on behalf of the pharmacy owners maybe don't know some of the information. And so it might either be left blank or the information may not be correct. And so as we're going through the application process, then we are identifying issues and inconsistencies between the information that is reported on the application itself and the supporting documents. So all of that then, right, irrespective of the type of deficiency, that can all lead to some frustration on behalf of applicants. And we're certainly not trying to, create, people feeling frustrated with the board or us being overly bureaucratic, but we do need to have confidence that the applicants for which that are seeking licensure meet the requirements of the law before we issue them a license. So I'm going to move on to the next slide, which really starts to talk about some of the different changes that we have made. And these changes will address in some parts the list of the common deficiencies. But like I said, there are certain ones that, confirming that the application is complete before you submit it. Those are some things that, applicants can probably, build that into their process to ensure that those kinds of deficiencies are remedied. So when we look at this, under our current process, we have a separate application. If someone is requesting a temporary license, we're going to move that into as part of the regular application as just an additional data point to collect, in the hopes that, not having to complete duplicate forms will help. We're also trying to incorporate some of the information that's required at the applicant level into the original application. Again, trying to reduce the number of forms that are required to submit, because we do find deficiencies in those forms where maybe signatures aren't there, dating isn't there. So trying to reduce the number of overall forms. We find sometimes that lease documents reveal violations of pharmacy law. So we are trying to add into the pharmacy application and attestation, as opposed to relying on the lease, as a way to help underscore the provisions of 1714, but also create an easier way to confirm compliance with that. We have combined some of the forms, the certification of personnel and the individual personal affidavit, again, reducing the number of documents that are required, streamlining the information a little bit, and then hopefully reducing the number of opportunities for people to provide forms that are not fully completed. If we can go to the next slide, please. So we receive a lot of questions about change of ownerships and changes of location. So this slide really kind of talks a little bit about some of the information that we have, but just as a general reminder, pharmacy law is very clear that licenses are non-transferable. So we need to just be mindful of that. This is an issue that we do find. And then this slide kind of talks about some of the information that is helpful up front as the board tries to help guide applicants in understanding what some of the requirements may be. Next slide, please. So this talks a little bit about the temporary pharmacy license application. So the board does have pretty broad authority to issue temporary licenses for a period not to exceed 180 days. if we determine it necessary. So generally, we're asking for the applicant to explain why the temporary license is issued, right? It's an underserved area. There's a change of ownership that is occurring, a change of location that has a date certain, and sometimes we don't have that information sufficiently far in advance to do it. So that's kind of what we're talking about here. If we can go to that next slide, please. We work really hard to try to make the community application instructions as specific as possible. And so there's pros and cons to that approach. We try very hard to detail out all of the information to try to assist, but I think sometimes people may find it a little bit overwhelming, the sheer volume. So we'll talk a little bit more about some of the things that we're trying through this new iteration to try to help maybe people not feel so overwhelmed. But our application instructions are by design intended to be very thorough to help guide people through a process. If we could go to the next slide, please. So we do try to include in our instructions a numbering that helps people link back to the community pharmacy application so that it's easy for them to understand exactly what the instructions are referring to in the application form. If we could go to the next slide. So under our current application, we have a checklist, but there's so much information in it that I think people might get a little bit lost in the checklist. So what we are trying to do is keep all of the good information, but have resource pages that maybe simplify it a little bit more. So this is an example of how we are trying to make it very easy for people to understand exactly what is necessary. It's really important to note that the information that is required is going to vary based on the type of ownership. And sometimes what we find is the people that are filling out the applications on behalf of the applicant may not have a full understanding of the ownership. And so that drives, regrettably, a lot of deficiencies because, just the information is not provided up front. And sometimes we do, unfortunately, get into a cycle with applicants where, we are requesting deficient items, and when we get those deficient items back and we're reviewing them, it's leading to additional questions. And so we're hopeful that if people, as they fill out the applications, have a full understanding up front of what is required, it is really going to help people submit applications more complete from the beginning. Next slide, please. So we do have a number of different types of supporting documents that are part of the application process. We do try to provide context on how to do that. These are some of the supporting documents that we are looking at. And what we will find sometimes is the supporting documents that are provided contradict information provided elsewhere in the application. So I think, again, it really comes down to sometimes making sure that the individual that is completing the application on behalf of the entity really has a strong understanding of the ownership, management, and control, because many times, regrettably, we do find that there's conflicting information submitted, and then that just leads to additional questions. Next slide, please. So we are going to be asking for information to support what the ownership is. By law, we are to assess management and control as well as ownership. And so the types of documents that are required depend on the type of ownership structure. And so really, again, it's really so important to provide all of this information up front, because when we find out things through the application process, it can lead to a lot of frustration and that cycle that we talked a little bit about. Next slide, please. So one of the other things that we're adding into the instruction sheets as well is a hierarchy organization chart. What we find sometimes is as pharmacy ownerships get more complex and there are additional layers of ownership, people may not have a really strong understanding of how to manage and what information is required for those various layers of ownership. So we are providing an organizational chart as part of the instruction sheet that's intended to try to demonstrate the types of information that we need through the various levels of ownership, as well as the different types of ownerships, right? So that the primary applicant may be a corporation, but that corporation may be owned by a limited partnership and an LLC, and then it goes from there. And so we're trying to differentiate through the organizational chart, hopefully an easy resource for people to understand based on the type of ownership and where they are in the organizational structure, the information that we need. So hoping that this, again, will help provide some additional information. So if the next slide, so this is how we communicate with people. It's primarily through email. We are building in, there's always a release included in there for the board to work with an authorized contact. We have found that sometimes we are communicating with the authorized contact, but perhaps that the communication with the board and the authorized contact may not be shared with the owner. So we are now trying to include both in the communications. The other thing that we're building in is we receive, through changes of ownership, we receive a lot of times inquiries from the prior owner of the license that is selling, asking for the status. And because pending applications are not public information, we can't share that information without a release. So we are building in a release for that as well, so that the applicant owner, if they give the board staff approval, we will share the status of a pending application with the current owner of the license. So the next slide just has the general information. For some complex ownerships, we believe that it may be helpful for the applicant to reach out, and they are welcome to reach out to me directly or to our senior licensing manager to request a meeting. Sometimes having the meeting up front and helping to guide through what will be required can be a helpful tool. Just want to indicate that when we do that, it is really important to have individuals participating in that discussion that really do understand the ownership of the license that is being sought. So with that, I know that was really high level. We will be releasing this information, and hopefully this will help to reduce the number of deficient applications that we receive, as well as hopefully reduce some of the frustration that I think some of the applicants feel when they are trying to secure the pharmacy license. So thank you again to all of the licensing staff that have worked really hard on this, looking at the trends and trying to build in improvements into the application process in the hopes that it does help the applicants.
Thank you, Anne. Thank you to all the licensing staff and council for undertaking review of the application process and working to provide applicants with additional information and to understand the requirements. So with variances in requirements based on ownership types, I believe the various charts illustrating the various types of ownership and supporting documents is very helpful. Just want to point out a couple typos, and which I'm sure we could just work that out as non-substantive changes. I do want to ask, if possible, to add a section under the where section C, supporting business documents, hoping to create a section for nonprofit corporations separately, as I believe there's a possibility of increases of nonprofit pharmacies and the business models in the coming decades as the profit margins for pharmacies decrease significantly. So I do see that as a possibility, and hoping that we're well prepared for that. Members, no action is required, but we are going to open for comments. And I want to note that the application requirements can be nuanced, and making general question and answers very difficult to answer in a general meeting format as this. With that comment, members, any thoughts, any comments? Don't see anything, so we're ready for public comment. I see nobody is in Sacramento, so I'm gonna move right on to WebEx starting from now on until I see someone in the room. Tricia?
All right, I've opened up the Q&A panel. If any member of the public has a comment on the presentation, please either raise your hand or type comment using the field in the lower right-hand corner of the screen. We are displaying instructions, and I do see we have several raised hands. We'll start with Min Hank Ho, Welcome Pharmacy, excuse me. You should be able to unmute yourself. There you go, you're unmuted.
Hello?
Yes, we can hear you.
Okay, great. First, I want to thank the committee and for taking on this issue and considering it. Just a quick intro. I am the authorized contact for an applicant. My wife is decided to take the plunge last year to apply for a pharmacy license. We're 10 months into our application. So, you know, at this point in time, it feels a little bit like waiting for a baby to come. We are just as anxious. That said, I thought it might be hopefully useful for a view from the other side of the table. A lot of what I'm going to share here probably won't help us any because we're kind of far along in the process, but, you know, maybe hopefully it'll help someone else who's further, you know, comes along and wants to open a pharmacy and do the same thing. We are trying to open independent pharmacy, so we're doing it ourselves. We don't have corporate lawyers. We don't have someone else, you know, helping us shepherd through this process. First, really agree with a lot of the feedback that I shared earlier. Definitely simplifying the form, providing more examples is really useful. I highly recommend providing a sort of a sample completed application rather than just the business organization. I also do my own tax forms, and what the benefits of, say, doing something like taxes, there's a lot of online resource showing you examples of what to do and what not to do. With pharmacy applications, honestly, there's not that many, right? There are relatively few pharmacy applications relative to individual pharmacist applications. So there's not a lot of resource we can turn to. So that would be incredibly helpful if there's just examples of, hey, this is what a completed form looks like. And I think I saw some of that. Case in point, even in the case of a deficiency response, we read very carefully, there's an instruction that said, any amendments to an application form requires the date, the word amended, and initials by an owner of a corporate officer listed on the application, ... So we actually took that instruction very literally. We literally took every word that was amended and put an initial next to it. When I think the instruction that we later learned was that all the board or all the license committee or I guess analysts needed was literally the word amended somewhere on the document. So if you had just a sample of what that looked like, we would have avoided a whole turnaround. Literally, we had to go back in line just for that. Totally agree with the lease sort of certification form. We actually got that in very initially with our landlord, so much so that it was embedded pretty deep in the lease. And because of the way that's structured, because every lease is different, I suspect it's very hard for the analyst to identify the correct language in the lease. A lot of times they expected it as an amendment, but we had it in the main body. And I think we got essentially turned around one time just for that, because we actually had it.
10 seconds.
Oh, sorry. Lastly, somewhere providing a flow chart of the process would be incredibly helpful. One thing that's easy to forget is that we have to sign a lease before we apply.
I'm sorry, due to time restrictions, your time limit was up, so I'm moving on to the next attendee.
Chair Sung.
Thank you, Trevor.
Yeah, would it be appropriate for an extension of that public comment? I'm very much interested in hearing the full extent of the testimony of the commenter.
Sure. Yeah, sure. Go ahead, Tricia.
All right. They moved back in line, so I have to just find them in the. There we go. try that one more time. Okay. All right, Min Hank Ho, if you'd like to unmute yourself, go ahead and complete your comment.
All right, thank you. I really appreciate the extra time. I'll try to be respectful. So the last comment I was going to say was that it's easy. One of the things that is required is that we have to complete a lease in order to even apply. And there's a clock that starts where the applicant essentially will have to pay. So these sort of delays, or at least not sort of a lack of visibility into the timeline it takes, results in an upfront cost for any independent pharmacies that want to open that is very hard to account for, right? So I'm at 10 months in. If we're really, if we're lucky, if someone's lucky and gets a conservative lease of $2 a square foot, you might be up to burning $50,000 if you're waiting a year for a pharmacy license to come through. And that essentially puts those independents at a huge disadvantage. So I just want the committee to take that into consideration, because any visibility would be incredibly helpful. Thank you for your time.
Thank you for the comments. And since we've extended a little bit of time for that gentleman, we're gonna make sure the public comments, they can speak for at least 3 minutes and 45 seconds. Go ahead.
All right, thank you. Next, we have Stephen Gray. And Stephen, you should be able to unmute yourself. All right, Stephen, we'll give that one more try. You should be able to unmute yourself. If you get a prompt, go ahead and click. There you go.
Thank you.
Yeah.
Thank you very much. This is not by any means my area of expertise currently. And when I get questions from people who are buying or selling a pharmacy or starting out on their first pharmacy, I always refer them to appropriate counsel. However, I do want to agree with the comment very much that there should be a special section for not-for-profit organizations. That was where I was very much involved for many years, and it was very confusing often to those people in the corporation that were in the legal office or the leasing office or whatever, what was different about the not-for-profit organization application process or structure or documents, et cetera, et cetera. So I really encourage you to focus on or have a ability to focus on a not-for-profit application because there may be things that are not required. There may be extra things that are required or the nature of things that are required. I also presume that the application of the slide was focused mainly on community pharmacies, but I think there's also a need for something similar for non-community pharmacies, outsourcing facilities, wholesalers, et cetera. So this is an excellent start. I will share it. I will refer other organizations that have asked me questions to go find this slide deck when it is made available. And so I need clear information about when and how that will be available. I know that the president asked for some possible modifications to it, et cetera. But I thank you very much. This is an excellent effort on the board's part to facilitate this, what can be a very frustrating, complicated, and expensive process. Thank you.
Thank you for the comments, Dr. Gray.
All right, next we have Stacy Neroni. Stacy, you should be able to unmute yourself. There you go.
Everybody, if you can't hear me, I guess ask me again. This is Stacy Neroni, and I have been working with the board on change of ownership applications and initial applications for over 25 years. And I can say that over the last 25 years, the applications and the process has gotten exponentially more difficult, especially because of all of the new ownership types and private equity getting involved in owning pharmacies and that getting more complicated. But additionally, in the review process by the board, and I really appreciate them going through these applications and trying to come up with ways to make it simpler. But the biggest problem is the length of time it takes. Like I said, I have been doing this for 25 years. I like to think that I submit very clean applications. For the most part, I don't think my applications ever have any of the deficiencies that were listed at the beginning of this presentation. But the board now goes into a detail of ownership requests to like the 0.00003% that somebody owns in a mutual fund who doesn't even know they're invested in a pharmacy. And there's no real reason that I can tell from the board's purpose. There's no protection for the public in knowing that information and forcing people to gather that information from investors who feel like their information should be kept private. There's no reason that the board can deny an application for somebody with that small a percentage of ownership interest and zero control interest. And I think that leads to a lot of the really, like, my applications are sometimes a foot thick because there's so much ownership structure. I can't imagine being an analyst at the board and getting the box with the foot thick application and having to go through that. I feel for them desperately. But my applications with private equity ownerships and levels of ownership that thick are now taking 1 year to 2 years to get processed. And for hospital systems that are just trying to open up a new pharmacy that already have 5 licensed pharmacies, it is hampering business and costing so much for entities to get this information and get these permits processed with zero ability to guess out how long it's going to take. The temporary permit process was initially established when it took about 3 months to get a pharmacy permit application, and you file a temporary application, you could get a permit in 2 weeks, or I've had one in a day. Now there's really no difference. You submit it because you should, but you get the temporary and the permanent almost in the same amount of time. It's always over 6, 8, 9 months. I think the board should consider a cutoff, like all the other regulatory agencies, Medicare, Medi-Cal, everybody. At a certain point, the ownership interest is so de minimis or the control interest is so non-existent that they don't require the applicants to provide that information. That would greatly reduce the amount of time the Board of Pharmacy takes to review applications and greatly reduce the complexity of the applications. And I really, really would request that happen, because additionally, the ownership structures are so complex, and the private equity companies are so concerned about their information being out that the board analysts really don't even have the expertise to understand and to analyze the ownership structures. I'm an attorney and I don't understand some of the tax consequences and ownership structures that various entities put in place. And we're talking about de minimis ownership interests, like all less than the 1%. And you're still required to keep reporting all the way up to humans. Luckily, the board is sometimes lenient with you. You know, I've had ones where it's like the Telephone Employee Credit Union of Colorado, and technically I'm supposed to list all the people who own that. And the board has been, you know, helpful in some degree to cut off when it gets really impossible. But I think the real issue with the complexity and the increased amount of timing is the depth into which the board reviews the ownership.
And that was 3 minutes and 45 seconds. So we'll move on to John Gray. John Gray, you should be able to unmute yourself. There you go, you're unmuted.
Yes, thank you. Good morning. This is John Gray, registered pharmacist with Kaiser Permanente. Just want to, acknowledge President O's call out of the application process for not-for-profit organizations, as well as Dr. Stephen Gray calling that out during his public comment. I would say, from our perspective as the largest not-for-profit health plan in the country, we feel that the mechanics of the application process to obtain a new pharmacy license work for us, and we're able to generally relatively efficiently get through the application process. However, we're also certainly happy to discuss, and I'd be happy to gather feedback from my colleagues who do the hard work of obtaining licenses to see if they think there's opportunity to improve the licensing process as it relates to being a not-for-profit. So, if that's something that the board is interested in me doing, just, I know that Ann knows how to get in touch with me. So, so feel free, and I can talk to my colleagues in our licensing teams in the North and South. Thanks very much for the opportunity to comment.
All right, this is a moderator. I see no further requests for comments. So, Mr. Board President, I return the floor back to you.
Thank you for the comments, Dr. Gray. I really appreciate both of your comments as well as Ms. Negroni. Just before I go to the next agenda item, I'm just gonna allow Corinne and Ann to just speak in general of some things that were said. I want to make sure that we give them the opportunity. Ann, Corinne?
Hi, yes, this is Corinne, Board Counsel. I just wanted to point out, for the clarification and to avoid any confusion, the board members, that, there is statutory authority for the board to ask for information about each person beneficially interested. So all owners of any applicant, as well as persons with management and control over the license. So that's, information that the board is entitled to ask for. And this is all set forth in Business and Professions Code 4201. And I would also point the board toward Business and Professions Code 4207, which gives very broad authority for the board to investigate, all matters related to applications, and says, notwithstanding any other provision of law, the board may request any information it deems necessary to complete the application investigation.
Thank you, Corinne. And did you want to add anything?
Yeah, I think the other thing that I would just quickly state, and I'm happy to work with the chair, is, we're happy to make some additional changes based on the feedback that was provided. I'm happy to do that. Also happy to provide some data specific to some of the information that was indicated through the public comment. We try to provide transparency with our processing times, and it's reviewed, on a quarterly basis, both by the licensing committee as well as, at the board meetings. So we provide some transparency there, but I'm happy to provide some information about timeframes. What I would say is not every application is the same. And so there are some applications that take longer than others. The complexity of ownership is something that continues to grow. We see many different types of ownership models than we have in the past. In addition to that, the statute changed, right? So pharmacy law is very dynamic. And, not only are we assessing for ownership, but also management and control, and that's by statute. And so to do some of that work, we require information. And regrettably, sometimes what we find is that people are hesitant to provide us with the information, or they're going to provide us information that's very redacted, making the work, challenging for both the board and I'm sure frustrating for the applicant. We are working very hard to fulfill our consumer protection mandate here. And the only other thing that I'll say is we have great partnerships, both with our DCA counsel, who has background in corporate law, as well as with the Office of the Attorney General. So we do partner with counsels as well as we are going through some of these things. So thank you for your time.
Thank you, Ann. Thank you, Corinne. And I just would like to say, finish by saying that as benign as it seems for pharmacy application, we have very clear requirement to make sure that anyone with the management and control are not any bad actors, and that, as benign as it seems for pharmacy applicants out there, we just cannot allow anyone, any bad actors to gain ownership in the United States and the California state's drug supply chain. So we're just trying to always be vigilant. And as frustrating as it may be for our licensees and applicants, there are quite a few things that our staff have to review. Members, any other comments before I move on to the next agenda item? Jesse and Trevor.
So I'm not super familiar with filling out pharmacy applications, but I did like the suggestion of maybe having a sample of a completed application or being able to provide a few. So if staff is open to providing that, I think that may be helpful for applicants.
If allowed, we'll absolutely try to work that out. Thank you, Jesse. Trevor?
Yeah, I just want to thank staff for their continual looking at this for ways that we can, again, maintain our consumer protection mandate while at the same time making sure that it's not needlessly arduous. You know, I mean, pharmacies are incredibly sensitive given both the opioid epidemic and wanting to make sure bad actors do not get access. And I'm just really grateful for the public testimony that has been provided because it feels like there's some middle ground where we can maintain our consumer protection, make sure that California's pharmacies are being protected and consumers are being protected from bad actors while minimizing unnecessary paperwork, whether that's figuring out, as was suggested, is there a percentage that we can clarify we don't need things for, whether that's 1% ownership or 2% or whatever that is. I'm not going to pretend to be an expert on that, but or talking about, like Jesse was just saying, providing as much examples as possible. This is always going to be an ongoing issue. Always, we're never going to find the perfect balance at any one point of time. But I'm just grateful for the authentic feedback we received today that can help us improve on that, and just very grateful for our staff and EO and everyone to be continually and constantly looking at this for ways that both streamline where it is appropriate to, maintaining stringency where it's also appropriate to, and constantly looking to find the balance in the midst of statute. So just wanted to put that out there, and I hope we can continue to improve this process for both stakeholders and for consumers.
Thank you for the comments, Trevor. Satinder?
I just wanted to add, besides the sample, maybe I don't know if this is feasible or not. I'm not saying the content of the application, what we ask could be changed, but maybe some of the people that are, for example, you know, regularly fill out the application and submit it to the board, maybe could be used as a focus group to test a new, provide feedback on the new form so that, you know, like easy or not easy or changes are, you know, before it gets rolled out. That's just a suggestion, like a user group sort of.
Thank you, Satinder. I don't know if, Anne, is that a kind of a possibility or probably not, but
Yeah, I think some of the challenge is going to be, I mean, we're totally happy to like reach out to a couple of people, but I think some of the challenge is that the ownerships really do vary, and there is a lot of nuance to each application, right? You talk even like about, even like a community chain pharmacy, right? You'd think that the ownership structures are the same. They're different, even among a community chain. So happy to, reach out to a couple of people, but it really sometimes is pretty nuanced. And so we're trying the best that we can. I think that if we're able to achieve a reduction in the number of deficient applications, I think that would also be a milestone that would show whether or not, we have, realized some of the goals that we are trying to do. I would also just kind of, should it be helpful information, There are a lot of applicants that maybe work with an attorney or a consultant to help submit their applications for them. And we find even in those instances variability between applications and what we receive with some applications that are with where the applicant received assistance submitting. They maybe are not including information, but it was submitted with another application where maybe it was the same, person assisting them. So, having said all of that, I did hear that John Gray was maybe willing to for Kaiser, and we can try to reach out to maybe a couple of others as well to ask for more specific. The only other thing that I will say is this is very much a public meeting, and if I think that people know how to reach the board. People are welcome if they have additional feedback that they either think of afterwards or as they're listening to me, go on and on. Sorry about that. Welcome to submit your feedback to us as well so that we can think about, if there are additional things that we can be integrating in. Feedback is always helpful. And, welcome to email it to me.
Thank you, Anne. And Renee?
Hi. Yeah, very complicated process, I'm sure. I was just wondering in terms of expectation setting, if there's information available, in this new sort of clarity of how to, like basically set the range that, it can take up to, whatever, I know you said there's quarterly review of the processing times. But fully also elaborating on the fact that, different application, every application is different, but this is a range of time so that somebody just kind of knows what they're getting into if that is available. And certainly, I thought it was a great idea to have somebody contact the board to discuss beginning the process, as opposed to maybe just logging in online and getting these, starting to work on this. Anyway, just a thought.
Thank you, Renee. Thanks for the comment. Okay, members, any other comments? Don't see anyone, so we're ready to move on to the next agenda item 8, discussion and consideration of proposed changes to application questions for individual licenses. The meeting materials include background on this next agenda item that stems from the federal Lorna Breen Healthcare Provider Protection Act, which seeks to address mental health challenges faced by healthcare professionals. I had the opportunity to learn about this act and Wellbeing First Champion Challenge during the annual meeting of the National Association of Boards of Pharmacy earlier this year. I applaud the goal of reducing stigma, enhancing support systems, and ultimately improving the well-being of healthcare workers. Members, I have reviewed the recommendations offered by staff and believe the approach offered is appropriate. If members are in agreement, I would like to request that staff confirm that the proposed changes would comply with best practices before developing an implementation plan. As indicated in the meeting materials, given that the pharmacy technician application is incorporated by reference in regulation, we will need to update the pharmacy technician application via the rulemaking process. All other applications can be updated and implemented more quickly. Members, I appreciate your comments on this recommended action offered by staff. And your thoughts, members? If you're supportive of this action, Satinder, go ahead.
I'm supportive. I like that it's simplified, just 2 questions. I don't have much to.
Thank you, Satinder. Corinne and Ann, should we just see if we can get a motion to do proposed technician application changes, or is that too premature at this point?
So I'm going to go rogue here. Sorry, Corinne. I think that probably if members are agreeable, if we can get approval in concept right now, I do think that there's a value in making sure that we are hitting the mark in terms of best practices before we go down the regulation route.
Okay, sounds good. I don't want you to go down the rabbit hole of 2 years of regulatory process and then sent back. So, okay, no actions are necessary. I will take your silence as an agreement of the proposal that is in front of us in concept. All right, sounds good. Ready for public comment? Anyone in WebEx? Tricia?
All right, if anyone would like to make a comment, please raise your hand or type comment using the field in the lower right-hand corner of your screen. We are displaying instructions and we'll give you a moment. All right, I'm not seeing any requests for comments, so Mr. Board President, I return the floor back to you.
Thank you, Tricia. If members are agreeable, as I believe you all are, I will monitor implementation with staff and will schedule public discussion on the proposed changes to the pharmacy technician application when appropriate to begin the rulemaking process. Next, agenda item 9, open discussion on payer practices that negatively impact patient care. As we prepare for the completion of the board's sunset report, one of the new issues identified for inclusion by the board is payer practices that negatively impact patient care. I included a discussion on this important issue to ensure the board has a full picture of the challenges patients face. For this portion of the meeting, if members are agreeable, I'm going to open for discussion for the public comment first, and then we'll come back to us. Tricia, public comment, please.
All right, if anyone would like to make a comment, please raise your hand or type comment using the field in the lower right-hand corner of the screen. We are displaying instructions and we'll give you a moment. All right, I'm not seeing any requests for comments, so Mr. Board President, I return the floor to you.
Thank you, Tricia. Sadly, we didn't get any public comment on this, but I guess I can start with some of the concerns I have, and main one being the pharmacy benefit managers mainly using auditing as a practice to recuperate funds that are paid to the pharmacies with citing a pharmacy law violation. And I do believe one of the main thing is that only the Board of Pharmacy are the ones that can actually enforce pharmacy law, not the pharmacy benefit managers. And I think that's one of the areas that I would like to highlight, and that hopefully we can incorporate that into the sunset, that they cannot be the enforcer of the pharmacy law, and that only the Board of Pharmacy are the ones that can actually enforce pharmacy laws. I have heard multiple feedbacks that they say that the pharmacy is violating certain requirements, that the prescription requirements have not been met, and that they are going to recoup and take the funds away from the pharmacy for violating a pharmacy law. And I think that just does not serve anybody any good. And so I do strongly recommend that that's one of the areas that we look at. Is there any other things that can come to your minds, members? This is an open discussion. So Jesse, I see your hand is raised.
Yes, sorry, I'm having trouble actually loading my materials now. I think it was pretty large, but did you have specific examples of that song?
That was one of them, that the pharmacy law violations being quoted by the PBMs as a reason for the recuperation of the money, as well as such as day supply issues that are constantly being raised, right? And the insulins and a lot of things that I think are in the jurisdiction of the clinical judgment is being used as a pharmacy law violations, but in reality, it is a clinical judgment of a pharmacist. So I think that's the one main area that I can think of. I don't know if, I think that Anne might have some better examples as well. So Anne?
not a better example, but one of the things that I would say that we see at the staff level are things that appear to delay the therapy of a patient. And so 733 provisions, extend to pharmacies, but what we don't see or have similar provision to ensure that, processes are handled quickly so that patients can receive their prescribed medications. This was a provision that was going to be in Senate Bill 966 that would have extended the provisions for 733 violations to PBMs. So just throwing that out as something that we see at the staff level that negatively impacts patients because they cannot get ready access to the medications. And it would be, I think at the staff level, we believe that this might be something that the board might want to consider pursuing through sunset or another vehicle to ensure that patients have timely access to their medications. Thank you.
Thank you. And I'll just add that also what I witness is that a lot of times our California law is very specific that I believe the prior authorizations or anything that requires prior authorization, if if it is submitted to the plan and if there's no response back within 72 hours, that it is supposed to be deemed approved. However, I can tell you what they will just tell you in my anecdotal experiences. They'll just tell you they never received it. And there's no enforcement related to it. Nobody ever enforces them. Even though the doctor may have a record of submitting something, they'll just say that they never received it and that, the patient just continues to wait. I know prior authorization itself is a beast of its own and it's a complex animal to deal with. But I think that there's definitely some opportunities in protecting our patients to get the medication that they rightfully deserve to get, especially for someone who's been on something and they're just trying to continue to take the medication they were given and they've been taking for a long time. So any interruption in therapy could really jeopardize their health and harm them. So Satinder, go ahead.
Well, I wasn't sure like how broad this needs to be, so I was gonna I wrote down some things. First of all, audit definitely. I feel like when it's pharmacy law broken, I've seen that come through. I agree with that. And prior authorization is the other one. You see a prescription, like especially when now with the shortages and something you needed to get a different drug that's not on the formulary, you request that. There's delays on those, and sometimes that can impact. That has impacted patients receiving a prescription on timely manner. Also, I see that in general, their practices of reimbursement and clawback practices has, as I noticed, my employer just recently announced, and I'm sure impacting community pharmacies too, just providing resulting in an access issue in some of the areas and having a pharmacy deserts. And I feel like there's other practices like there's tiered formularies where the cost becomes prohibitive for patients to receive their medications. That causes a negative impact on prescriptions or mail order. This first two needs to be filled at the pharmacy, then it's mail order, which causes confusions for patients and results in access to medication in timely manners. So I think there's a lot of these practices over the years that just become really onerous and resulting in a frustrations for the consumer getting prescription on timely manner. So those are just some of the few things I thought of.
Thank you, Satinder. Jesse?
So, I wasn't sure if this is quite what we were referring to, but in my experience, we'll have audits specific to like instructions, for example, on creams or topical medications. So say a doctor writes apply to affected area and doesn't write like a specific day supply, doesn't have the body part. That is essentially the PBM deciding what creates a valid prescription or not. And that definitely leads to a delay in care. We have a lot of people who have like acute allergy symptoms or infections that need to be provided. And And so what ends up happening is that from the pharmacy end, a lot of companies will prohibit or require pharmacists to follow up with doctors' offices, and we may not hear from them right away. The other piece that I think we should discuss a little bit is the rebates. So just from the perspective of being at the staff level in a chain pharmacy, there are rebates that happen that are at the corporate level that we're not really privy to from the pharmacy level. So a PIC may look through their profit and loss statement and say, hey, we have to accept, you know, XYZ discount card, even though we may be in the negative or only 11 cents per prescription that, you know, that we're actually getting in profit. But what we're not seeing is that in the back end, our corporation is actually getting money later. But the reason why that's bad for patients is because ultimately that's going to affect our staffing levels and how much support patients actually get when they go into their pharmacy. So I think that's something that we have to look into too. I personally hate rebates. That, you know, everything should be as transparent as possible. And I'm sad that the bill got vetoed, but there definitely needs to be change at some point. I just don't know how we're going to do it.
Thank you, Jesse. Yeah, rebate alone, that's one aspect of rebate, but I think there are so much bigger, crazier back-end rebate that I think most likely it's gonna be hard for us to tackle, but at least we can attempt to get a little bit of a better insights into the rebates, because it does affect patients directly. Because I think that a lot of times patients are asked to pay a lot more than what the actual health plans and the PBMs and the plan sponsors are paying for that. But because of their deductibles and whatnot, patients are asked to pay significantly more money than what they actually should have paid. There's so much with rebates that are just such an interesting, crazy beast. Any other member comments? All right, members. If you all are agreeable, this would be, I think, okay for me to work with our staff to develop some potential solutions for the board to consider as part of maybe November or December board meeting. Moving on to the next agenda item, discussion and consideration of licensing statistics. Members, the meeting materials include a summary of the licensing statistics for the first 3 months of the fiscal year. I note improvement in processing times for pharmacy and non-resident pharmacy applications. I'm also very pleased to see that with the exception of designated representatives, processing times for all individual applications are under 30 days. Thank you to all of our licensing staff again for working so diligently to process applications. I just really would like to, again, sincerely thank licensing staff. You all work so hard. I know it is a lot of work. So thank you all for what you do. Members, any comments? Seeing none, ready for public comments. Trisha?
Right, I've opened up the Q&A panel. If any member of the public would like to comment on agenda item 10, please either raise your hand or type comment using the field in the lower right-hand corner of the screen. And I see Stephen Gray with his hand raised. So Stephen, you should be able to unmute yourself.
Yeah, thank you very much. First of all, forgive me, but I think we should have had public comment on the previous topic after you had so much comment from members. You asked for public comment first, then you went to a lot of comments from the members, and I think it would be helpful to the board to go back and have some public comment about some of the items that were stated by the members. As far as public...
Let's, you know what? That's a great comment. I'm sorry to cause confusion. We can roll back to the previous agenda item. So do you want to just speak on that first, if you had anything?
Yes.
We're going back to agenda item 9. I'm sorry. I think that's a good comment, Steve. Thank you.
Okay.
Go ahead, Steve.
Thank you very much, Sung. I really appreciate that. And I think I can be helpful. Your first thing you talked about was when there is an audit that where the audit identifies some violations of law, and that's challenged as causing a non-reimbursable. I think you need to be very careful there, because there is federal law, for an example, that basically would hold the payer responsible as a false claim if there is any violation of pharmacy law connected with the claim that is submitted by the payer. So payers have to be very conscious of that. Some of the things, for an example, is the pharmacist that filled the prescription may be on the federal blacklist for even participating in filling the prescription that was, other little things. There was a huge case where refills were not legally authorized by a prescriber. And but the pharmacy was continuing to refill them by just taking a quick answer from whoever answered the phone in the doctor's office and said, yeah, go ahead and refill it. All of that went back 4 years and cost the payer tens of millions of dollars in false claims. So you can't just say that, that the payer doesn't have some responsibility for making sure that the law was followed. And you can probably have a lot more discussion on, where they may step over the line. The other thing is a lot of the pharmacy managers, even some of the pharmacy upper staff, are not aware of the law that's already on the books in California that puts restrictions on PBM auditing practices. That's in the statute now. It's in the posted pharmacy law book. And some of those, may be some of the frustration that pharmacies are experiencing, and they should refer themselves. There is no board authority theoretically to enforce those, but there is private action available, and some law firms have already sued PBMs for violating those audit practices that are listed in California law. So those are my comments, and some of the other examples that we got into are clearly not, or probably not. It needs to be analyzed within the jurisdiction of the board and come under the California Department of Insurance or California Department of Health Plans regarding tiers for benefits and so forth. The basic assumption is that the patient knows what contract they or their employer signed up for, and they're held to those contracts. And if that says they have to get prior authorization, that would be the basic laws. And I don't believe that even 733 can delve into that. But again, I think that's just part of the analysis you should ask for before going forward. So thank you very much for letting me point out some of those things. And hopefully some other people on the phone will also point out some issues that might be helpful, because there are definite issues related to patient care that may be involved in certain pay practices. Thank you.
Thank you so much for the comments. I apologize, everyone. So we're going back to agenda item 9 and opening for public comments for that agenda item 9. So anyone else have any public comments for agenda item 9 on open discussion on payer practices? Please raise your hand. Kind of quiet audience today. I guess not.
Yes, I'm not seeing any raised hands or requests for comment.
Okay, thank you. Thank you, Tricia. Okay, moving back up to agenda item 10, discussion and consideration of license statistics. Tricia, if you could open up for public comment one more time for this agenda item.
All right, so if anyone would like to comment on agenda item 10, please either raise your hand or type comment using the field in the lower right-hand corner of the screen. We'll give you a moment. All right, I'm not seeing any requests for comment. I return the floor back to you, Mr. Board President.
Thank you, Tricia. Thank you, everyone. Any member comments before we adjourn for the day? All right, members. Before we adjourn for today, I'd like to thank everyone for your time and participation. Our next meeting is currently scheduled for January 9th of 2025. I hope everybody have a great well, we'll see you all in about a couple weeks. But still, I guess in this meeting will not happen until the next year. So hope everybody have a great rest of your year, and we'll see you all in a full board meeting in few weeks. Thank you, everyone. Have a great day.